This afternoon I'm going to be presenting on tests of lung function in the assessment of asthma. The topics, oops, if I can get my screen to go forward. The topics that I'm going to speak about specifically in the next 20 minutes or so are spirometry, static lung volumes and bronchial provocation tests in the assessment of asthma. So as you're probably aware, spirometry is probably the most common objective assessment of respiratory function that we do for assessing asthma and diagnosing asthma. And in simple terms, it's just the measurement of air moving in and out of the lungs, and it can be performed under relaxed conditions, or it can be performed under forced conditions. And forced conditions is the spirometry that we generally use in the assessment of asthma. So that's a patient on the mouthpiece breathing normally, taking a really big breath in till they're very, very full, and then blasting the air out as hard and as fast as they can until they're very, very empty. And from that, we can calculate some parameters of spirometry and make some assessments about the health of the lungs and the amount of airflow limitation there may or may not be. Spirometry can be a little bit tricky to do. While it sounds in simple terms that it's easy to perform, there's actually a lot of different aspects that go into the performance of spirometry, and really spirometry should only be measured by trained healthcare professionals. And there are plenty of training programs around Australia and New Zealand that look at teach spirometry performance. On the screen, you'll see that here are a number of examples of portable spirometers that you might find in primary care. We probably use more complex machines that also measure other aspects of lung function in complex lung function labs. So in terms of some of the parameters that you will see when you're performing spirometry, first of all, when we perform spirometry, we have a graphical representation of spirometry, and that may be in the form of volume time curve. So we have time along the horizontal axis and volume on the vertical axis. Patient breathes normally, takes a big breath in till they're very, very full, forces the air out as hard and as fast as they can until they're very, very empty. So this is showing inspiration and expiration. This is just another a graph of volume against time, but it's only showing the expiratory part of the curve. So the patient's taken their big breath until they're full, they hop on the mouthpiece, they blow out as fast as they can till they're empty. We can also show spirometry via what are called flow volume loops. So we have volume on the x-axis this time and flow on the vertical axis. Patient breathes normally, takes a big breath until they're very, very full, blasts the air out as fast as they can until they're very, very empty. When they've got absolutely no air left, they breathe back in as fast as they can till they're full again. In terms of the primary parameters that you really need in terms of interpretation of spirometry, really you need to know the FEV1, which is the forced expiratory volume in the first second. So if we look at the volume time curve here, we move across the time axis till we find 1 second. Follow that up till we hit the curve and then read that volume off, and that's the FEV1. The forced vital capacity, or sometimes also the vital capacity, is the maximum volume that can be exhaled from total point of total inhalation to a point of total exhalation. So in this case, the patient blows out from a position of being really full all the way out till they're very empty, and this volume that is read once again off the volume axis is the forced vital capacity. And then we look at the ratio of the two, so the FEV1 divided by the FVC, and that gives us an idea of how open or closed the airways are. The lower the number, the more airway narrowing that there is. The other important aspect in terms of assessing asthma is to look at bronchodilator response. So we perform spirometry before and after administration of a short-acting bronchodilator, and this can be useful for assessing if there's any reversible airflow obstruction. The definition of a significant bronchodilator response is defined as an increase in either FEV1 or FVC that is at least 12% and also at least 200 mils. So you need to see a percentage change and an absolute volume change in either FEV1 or FVC to define that as a significant bronchodilator response. The other important aspect for assessing bronchodilator response is that if we do see a response, to describe whether the bronchodilator actually returns spirometry to within normal limits or not. So is there complete resolution of any airflow limitation, or is there's only partial reversibility, so there's incomplete reversibility. In terms of asthma and respiratory medicine measurement, there are a few different manifestations that you'll see with spirometry. Probably the most commonly presumed manifestation of asthma with spirometry is that you'll see airways obstruction when you perform spirometry, and then you'll see reversibility when you give bronchodilator. But this is not always the case, and particularly in diagnosing asthma, there are not always symptoms present at the time that we perform the assessment. So in fact, spirometry may actually be within normal limits when we perform the testing, and there may or may not be reversibility with bronchodilator. In asthma that has not been well controlled over years, you can see airways obstruction on spirometry that may not have complete reversibility when we give bronchodilator, and sometimes you don't see reversibility at all. The other manifestations of asthma that you can sometimes see is obstruction of the airways, resulting in a reduction of both FEV1 and FVC, such that the ventilatory pattern appears to be more restrictive than obstructed. And when you give bronchodilators, there may or may not be complete reversibility of that airflow limitation. And I'm going to go through a few cases now to illustrate some of these different patterns that you see. So just to orient everyone to the slides for the cases here, we have the demographics up the top of the slide. We then have the parameters of spirometry in the first column here, FEV1 FVC and the FEV1 FVC ratio. The next column across tells us the pre-bronchodilator or baseline spirometry results that the patient actually blew. The next column across tells us what the lower limits of normal are, so where the normal range begins. The third column across tells us the percent predicted of FEV1, which can be useful when we see obstruction in describing the severity of obstruction. I'm not going to speak about that today for the sake of time, but it's just there for completeness. And then we have our post-bronchodilator results, and the final column tells us the change between the baseline results or pre-bronchodilator results and the post-bronchodilator results, which helps us to assess for reversibility as a result of bronchodilator. So this case here illustrates what we most commonly expect to see if we're querying asthma, that in baseline or pre-bronchodilator spirometry there is obstruction, and obstruction is defined as an FEV1 FVC ratio below the lower limit of normal, okay? And that when we give bronchodilator, we see a greater than or equal to 12% change in FEV1 or FVC that is also more than 200 mils. So as you can see for this example here, the patients increased their FEV1 by 500 mils and 12%. So there's a significant bronchodilator response. And when we compare their post-bronchodilator results to the lower limits of normal, their results are now within the normal range. So there is complete reversibility of any airflow limitation. As you can see here, we've got the flow volume loop. The red line represents the baseline spirometry. The blue line represents the post-bronchodilator spirometry. The FEV1 is identified by these little tick marks here. So you can see there has been a significant shift in the flow volume curve. Case number 2 is what we often see when we're asked to diagnose asthma in people who complain of symptoms. So in this case here, you can see that when we look at the FEV1 FVC ratio, it's well within the normal range, as are the FVC and the FEV1. So pre-bronchodilator spirometry is in fact within normal limits. And when we give bronchodilator, we see no significant change in FEV1 or FVC. So this is a common occurrence, and I suppose the question is, when we see this but we are conscious that the patient has symptoms, then we need to think about what other tests we're going to perform, and I'll speak a bit more about that in a couple of slides' time. Case number 3 illustrates a patient who we're querying asthma in, but when we look at their baseline or pre-bronchodilator spirometry, once again, it's within the normal range when you compare it to the lower limits of normal. But what we do see when we give bronchodilator is we see a significant change in either FEV1 or FVC. So sometimes, although we can't say there is obstruction in this pattern, because we do see a positive bronchodilator response, that suggests that there is some reversible airflow limitation. And so we need to be suspicious that there may be something like asthma present. But obviously, probably one of the other really important things to think about is that we never make a diagnosis based on spirometry alone. So there needs to be some clinical correlation as well. This example here shows a patient who has obstruction on baseline spirometry. When we give them bronchodilator, we don't see any difference. So if we were looking at this at face value, we would note that there is obstruction on spirometry with no significant response to inhaled bronchodilator. It's really important that you also read technical comments that are provided by the operator when you're reading a lung function report, and you'll note that the operator in this case noted that the test performance was good, but also noted that baseline FEV1 fell with consecutive efforts and they could not match the best baseline result. So if we actually look at the efforts that this individual made with each test that he did, you can see that this time is increasing in time here. These are his baseline results, that his first FEV1 was 3.04, which was his best. The second one was 2.70, third one was 2.66, and the last one was 2.39. His FVC didn't change much, but sometimes you can also see a fall in FVC. After we gave him bronchodilator, we actually were able to get him back up to his best baseline results. So as I said, although it looks like on face value there's no significant response to bronchodilator, in fact this patient probably has hyperreactive airways. In other words, just through the process of performing spirometry, we're actually causing his airways to become a bit twitchy and his lung function is falling. So to diagnose hyperreactive airways, which may indicate that the patient has asthma or not well controlled asthma, we're reliant on the test operator to advise of this pattern in their technical comments. In terms of how commonly you see it, we test 11,000 patients a year and we'd only see it a handful of times each year. Case number 5 shows a female with asthma as well. As you can see in this example shows that on baseline spirometry, the patient appears to have a restrictive defect, but has a significant response to bronchodilator that returns spirometry to within normal limits. So this could be another manifestation of asthma and poor control. The final case I want to show you right now is, well actually it's not quite the final case, is a patient who has severe airflow limitation based on their FEV1% predicted. When we give them bronchodilator, they have a really big response to inhaled bronchodilator, but it still doesn't return their lung function to within normal limits. They do have, but it does return their FVC to within the normal range. So in fact, we know they don't have a restrictive defect, that the reduction in FVC on baseline is due to airflow limitation. And case number 7 shows a case of, once again, a patient who appears to have restriction on baseline spirometry, who has a significant bronchodilator response, but the results still sit below the lower limit of the normal range after bronchodilator. And we can't tell whether the reduction in FVC is simply due to airflow limitation or whether there may be some restriction as well. In this case, we can measure what are called static lung volumes and look at the total lung capacity, which is this top parameter here. Total lung capacity tells us the total size of the lungs, and if it's within the normal range, here's the lower limit of normal here and here's the upper limit here, then that suggests that there is no restriction. And in fact, if you look at the RV-TLC ratio, which is the ratio of the residual volume, so the amount of air that's left in the lungs when we breathe out till we're completely empty compared to the total amount of air or the total size of our lungs, you'll see that that value there is elevated compared to the upper limit of normal and suggests that there's some gas trapping. So the likelihood is that this reduction in FVC is in fact due to airflow limitation. Bronchial provocation tests can be useful for assisting diagnosis of asthma when we find spirometry at assessment is within normal limits. So if we have a look again at case number 2, although the query was asthma, we can't exclude asthma in this case, even though lung functions within the normal range with no bronchodilator response. And there are two different types of challenge tests that you can do. There are direct challenges and there are indirect challenges. Direct challenges, it's the agonist or the mediator that's administered. So we give histamine or methacholine, and it acts on a specific receptor on smooth muscle in the bronchioles to cause it to contract and the airways to narrow. Indirect challenges, on the other hand, the agonists or mediators are released from inflammatory cells or neuronal cells in response to a stimulus, for example, an allergen, dry air, or an osmotic change. Responses to indirect challenges can be inhibited by some medications, so you need to keep that in mind in terms of test preparation. This little schematic here basically shows where bronchial provocations act along the inflammatory pathway. So methacholine or histamine challenge operate by impacting directly on bronchial smooth muscle, causing contraction and airway narrowing. Hypertonic aerosols such as hypertonic saline or mannitol, they are inhaled and they increase the osmolarity of airway surface liquid, which then impacts the epithelium and submucosa. And if there is inflammation present, then this causes release of various mediators from mast cells and things like that. And that mediator release then acts on bronchial smooth muscle to cause bronchial muscle contraction, airway narrowing. Exercise or eucapnic voluntary hyperpnea challenges, they act on the inflammatory cascade by drying out the airways and causing water loss from those airways, which increases the osmolarity, and then a similar pathway is followed. In terms of sensitivity and specificity for asthma, direct challenges have a really high sensitivity but a low specificity, so they're useful to exclude current asthma except for exercise-induced bronchoconstriction. I don't have time to speak about that today, but just keep that in mind. And indirect challenges have a low sensitivity but a high specificity compared with the clinical diagnosis of asthma. So if there is a positive result, it's useful for confirming current asthma. If it's a negative result, then we can't exclude asthma. Indirect challenges, which is what I'm going to focus on in the next couple of slides because I'm nearly at the end of my time, are useful to assist in identifying airway hyperresponsiveness that's consistent with the diagnosis of asthma, to look at airway hyperresponsiveness that will respond to steroids, and is consistent with exercise-induced bronchoconstriction. So they can be used as a surrogate marker for exercise-induced bronchoconstriction. Some indirect challenges can also be used to assess asthma control. The two indirect challenges that I'm just going to mention briefly are the mannitol challenge and the eucapnic voluntary hyperpnea challenge. So the mannitol challenge comes in kit form, which makes it very easy and convenient to use and deliver. It is a cumulative dose challenge test. So you'll see on here that there are little numbers which tell you what to give at each step. So you start off with a single capsule that has 0 mannitol in it. If you see no change on that dose, you then give a single 5 milligram dose, 10 milligram dose, 20 milligram dose, and then you get up to 40 and 160 milligrams in the end. After each dose is given, we repeat spirometry and see if there's been a fall in FEV1. The eucapnic voluntary hyperpnea challenge is a single dose challenge. What happens is the patient breathes a dry gas mix where we keep carbon dioxide level constant so that they don't blow off their CO2, and we get them to ventilate as hard as they can for a period of 6 minutes. We'll have performed spirometry prior to them doing this, and then after they've breathed as hard and as fast as they can for 6 minutes, we then monitor their spirometry and look for this drying of the airways and the inflammatory cascade to be triggered. So if we go back to case 2 again, which who was the lady who they were querying asthma in, that we saw no obstruction on baseline spirometry and no bronchodilator response. She went on to have a mannitol challenge on a separate day. You can see here, this is her baseline spirometry that was performed, which shows that it's still within the normal range. These are all the doses, cumulative doses of mannitol that she had, and you can see that after 475 milligrams of mannitol being inhaled, she had a 19% fall in her FEV1. The threshold for a positive challenge with a mannitol challenge is 15%. So as you can see, her FEV1 fell, and then after we gave her bronchodilator, it returned to being very similar to her baseline levels. So this would suggest that she has current asthma. Case number 8, which is the last case I'm going to show you, is a case of an 18-year-old male who has recent onset of exercise-induced wheeze and cough, who on baseline spirometry with bronchodilator showed lung function within the normal limits, so we couldn't exclude asthma. He came back at a later stage to have a EVH challenge. As you can see, once again, his baseline spirometry was within the normal range. Having breathed dry air with a 5% CO2 for 6 minutes, we measured his FEV1 at 1 minute after the end of that breathing period, and you can see that he had a dramatic fall in his FEV1, fell more than 44%. A positive challenge with an EVH is considered to be a 10% fall. You'll also note here in the tech comments that the scientist noted that the patient had to have 900 micrograms of Ventolin, and it took them an hour to return to their baseline levels. So sometimes there can be a challenge getting them back to normal before we let them go as well. So in summary, be careful using spirometry to diagnose asthma. It can manifest in a number of ways, and you can miss it if you're not thinking about the clinical picture and the symptoms at the same time as you're looking at the results. Abnormal results may not always be present when asthma is stable or well controlled. And you can use other assessments such as bronchial provocation tests, static lung volumes, and some other tests that I haven't discussed today, but that Greg may mention in his talk following, to assist with the diagnosis and management of asthma. Thank you.
Fantastic. Thank you very much, Bridget, for that presentation. So we now have a couple of minutes for questions, if we have any urgent questions, and there'll be more time at the end of the second presentation for questions from the speakers. Do we have any questions from the local audience here? No? I think we'll go straight on to Greg's presentation then. Thank you very much again, Bridget. Please join me in. Thank you. All right. I'll make Greg the presenter here. Fantastic.
Thanks very much, Steve.
So I'll just briefly introduce Professor Greg King, based at the Woolcock Institute of Medical Research and the University of Sydney. He's a staff specialist in respiratory medicine and a research academic, and one of the chief investigators of the Center of Excellence in Severe Asthma. His clinical and research interests are in airway diseases, particularly asthma, COPD, bronchiolitis, and obesity, and their impacts on lung function, including ventilation distribution, airway closure, airway hyperresponsiveness, and remodeling. So thank you, Greg, for presenting, and look forward to hearing what you have to say today.
Great, thanks a lot, Steve. Is presentations on screen, is it? I assume it is. Okay.
That's correct.
I'm going to talk about the how I use lung function, and I'm going to speak about this from a clinician and clinician researcher's perspective. I know in the title that imaging was mentioned here, but I think given the amount of time and the messages I wanted to give, I had to prioritize something. So I'm going to talk about how I would use normal lung function in the process of mostly with assessing asthma, and in particular severe asthma, and also talk about forced oscillation technique in the latter part, which I think is one of the methods that we will use in the future of the way that we manage asthma, in fact, perhaps other airways disease. So where does lung function testing fit in with the way that I guess I manage asthma? And why is lung function monitoring important? I'm going to hopefully show a lot of the reasons why I think lung function is really important to measure and how it can be really useful in a single case. So this chap I initially saw about 4 months ago, and I saw him again for review in last Tuesday as part of one of the patients coming into the severe asthma clinic. So this man, Mr. AN, is 54 years of age. He's otherwise completely well. He was on no other regular medications except for salbutamol, and he has a very small year history of smoking. He doesn't smoke anymore, and he presented with shortness of breath and wheeze in winter, and he gets very occasional symptoms. In winter he had relatively frequent symptoms, perhaps every few days, but when we saw him it was winter and he hardly had any symptoms. And an important part of the history was that salbutamol improved his symptoms, but he rarely needed it. And I guess the doctor, his GP, thought he had COPD because he was started on umeclidinium. But he himself found it was of no benefit. He hardly had any symptoms anyway, and he ceased it himself. His past history includes occasional hay fever, sinusitis, and postnasal drip, and he had occasional gastroesophageal reflux symptoms. His occupation was a musician and music teacher, and he didn't have any significant occupational or recreational exposures to any fumes, toxins, etc. And on examination, he looked very well. He was slim, he had a normal SpO2, oxygen saturation on room air, and his chest was clear, but his nose was a little bit blocked. I saw a recent chest x-ray, and it just suggested mild hyperinflation, which I didn't think too much of, given that he was pretty slim. So in summary, he looks well. He presents with wheeze and shortness of breath in winter of this year. It's a bit suggestive that he might have asthma, maybe he has bronchitis, maybe he had a lot of hay fever or a lot of allergy, who knows. And a pretty normal examination. So for some reason or other, he didn't have lung function tests on the day that he saw us, where we normally would do lung function on our patients, particularly all the new ones before they came to see us on that day. And our registrar who saw him, I saw him with the registrar, started him on fluticasone based on the strength of his history and showed him how to use the spacer, and off he went. So he came back in a couple of months and he has a peak, so we obviously asked him to measure peak flows. Peak flows were between 250 and 370 litres per minute. And he reported he hardly had any symptoms. So he stopped the fluticasone. So he monitored for a short time. When the fluticasone ran out after a month, he stopped that and he stopped the peak flow monitoring because he was feeling really well. And he thinks he got a bit better. And I measured his ACQ at the time that he came. And there it is. He has an average ACQ of 0.6, which would suggest that he's got very few symptoms, that he's either very mild or he's not obviously not on any treatment. So he's not, we wouldn't say that he's well controlled because we're not giving him anything. And he did his lung function, and here's his lung function. And we all got a bit of a surprise. I guess maybe me, I'm not so surprised these days because I've seen this many times before. He has quite significant airflow obstruction on spirometry. You can see his FEV1 to FVC ratio is 0.49. His FEV1 is 57% of predicted. You can see the very large bronchodilator response, but he has persisting airflow obstruction. This really demonstrates one of the really important uses of spirometry. I asked him at the time how he felt at the time he did the lung function, and he said, normal, just like I do today. And in fact, I think he had this lung function on the day that he saw us. And you listen to his chest, and it's quite normal. He has normal lung volumes, and he has normal subdivisions of lung volume. You can see the residual volume is a bit high, but the RVTLC is actually normal. So I would have reported this as having normal subdivisions of lung volume and normal lung size. So in summary, he has very few, if any, symptoms since we last saw him, and he's come off treatment. But he has very poor lung function, and he has persisting bronchodilator responsiveness. So he demonstrates a risk factor for severe asthma, and on those two references there, they demonstrate they describe the association between bronchodilator responsiveness and the risk of mortality and poor outcome in two population studies of asthma. So he has a consistent history of asthma, and the bronchodilator response and the peak flow recordings suggest that he has uncontrolled asthma, but the difficulty is he's got pretty much no symptoms. So we do the usual thing. We talk to him about his asthma. We confirm the diagnosis of asthma with him. We say that it's a lifelong thing with him. He's not going to outgrow his asthma. We talk about inhaler technique. We talk about an action plan, and we say, we want you to go back onto treatment. And we explained why it's important for you to have treatment, and you're likely going to need it for most of your life, if not the rest of your life. And we'd like you to continue peak flow recording. And we'll see you in 2 months. 2 months later, if anything, his pre-bronchodilator spirometry is a bit worse, and he's still demonstrating this big bronchodilator response. So you can see the big change in FVC going from 3.73 litres up to 4.53 litres. 800 ml change of any lung volume, forced expiratory volume, is, in my book, big, and his ratio is persistently abnormal. I've also shown there from our lung function the forced oscillatory impedance, where it shows the resistance of 5.8 and the post-bronchodilator, again, a large response. You can see how we classify significance or not down in the bottom right corner. And you can see the reactance, the X value, which I'll speak about later, that also demonstrates quite a significant change from minus 3.29 to minus 1.09 centimeters of water per liter per second. So that's a big change in FVC as well. So the two lung function measures match up pretty well. And here is his peak flow recording from that period. So what I've shown you is my peak flow recording, and I did this just to demonstrate what normal peak flow variability or peak flow variability in a non-asthmatic person should be. And it's roughly like this. And I've measured the variability as a percentage of the best, of the recent best. And the rough recent best is about 730 litres a minute. And the difference between the best and the worst, between 730 and 680, is about 50. So 50 as a percentage of the best, 730, is 7%. And in my head, I have a rough number of about 10% for normals. So healthy individuals might demonstrate a variability of around 10% in peak flow. So you've got to know obviously what peak flow variability is in a non-asthmatic person to be able to make any sense or interpretation of what peak flow variability is when it is abnormal. So my guide is 10%, and that's 10% of best. You can see in this man that the variability, actually this thing is blocking my view. I think I've written there it's about 44%. So he demonstrates really large amount of variability. And again, symptoms, hardly any. He has hardly any symptoms. So again, in this visit, we try our best to assess his adherence to medication. We check his inhaler technique, make sure he's using the puffer and the spacer really well, and make an assessment of whether he has other significant contributing factors to this lack of control. So at this stage, I want to mention the Severe Asthma Toolkit, which is on the CRE for Severe Asthma's website. And it's an online document put together by many of us who treat and study severe asthma across Australia. And hopefully there are some really useful resources which are all hyperlinked. And what I've got here is the initial assessment and definition of severe asthma. And this definition, although it's really short and really simple, I think that is, I think all anyone would need to know about how to define severe asthma. It's the presence of uncontrolled symptoms due to variable airflow obstruction despite optimal treatment. And of course, with this man, I don't think he's clearly not on optimal treatment at the moment. We've got him on inhaled corticosteroids only. And I actually really did think that he would had a good chance of come under good control with 2 months of regular inhaled corticosteroid treatment and what we assess to be pretty good adherence to that treatment and using it properly through a good device and him using the device properly. We've not optimized this treatment, so you would probably guess that we've added a long-acting beta agonist to his treatment and keeping him on high-dose inhaled corticosteroids. So I think for him, it demonstrates that confirming the diagnosis of severe asthma takes a long time, and we haven't done that yet. And it really, for me, demonstrated, and this is relatively common in a severe asthma clinic, the value of using objective measures and how spirometry can be really, really critical to the assessment of a particular person. And I've obviously stressed the importance of symptom perception in this case. Peak flow recordings reveal day-to-day control or lack of it. And I strongly believe in the value. In fact, I believe that anyone who's working in a severe asthma clinic or sees a lot of asthma should be very, very au fait with peak flow recordings and being able to get their patients to use it. Of course, we wouldn't expect everybody to use it every day for the rest of their lives. That would be completely unreasonable. But it's useful, particularly in the initial assessment phase and when you're trying to gain control and when there are difficulties in managing a person's asthma. Asking symptoms at the time of spirometry and matching it to the peak flow recordings are, I wouldn't say just very important. I think it's a critical part of the assessment of that particular individual's asthma. Okay, so that is really an illustration of how I think lung function testing is absolutely important and critical to assessment of asthma. And we know that it's not done very frequently at all in general practice. It's all done by symptoms. We know why that tends to fall down, because symptoms can be very deceiving. And so what's the alternative, and what can we do in the future? Well, my opinion is that the way that we think about asthma and monitor asthma must change if we are to do anything different than treat with bronchodilators and steroids. I know we do treat, we're now using biologics, and there are going to be more drugs targeting severe asthma, but that only affects maybe 2% of the asthmatic population that we're treating. The rest of the population, we're going to be stuck with inhaled corticosteroids and bronchodilators unless we look at things in more detail, and clearly objective testing is part of that. And objective testing from my end of the world is about lung function testing. Of course, there's objective testing using biomarkers of many different types, whether it be blood, sputum, exhaled breath, or whatever. But I'm only going to talk about one aspect of it, and that's lung function testing at home. Nobody wants to do peak flows long term because it's very difficult. Patients hate doing the forced blows every morning. Hence our interest in the forced oscillation technique. The forced oscillation technique is a way of measuring the mechanics of the lung, but it's done under tidal breathing conditions in most situations. And it's done by using a pressure oscillation, usually generated by a loudspeaker, but they can be generated by all manner of mechanical devices, applying it at the airway opening and superimposing it onto tidal breathing. The pressure oscillations enter the lung, and the response is flow. So we know what the pressure going in is, we measure that, and we can measure the response, the flow. The most common oscillatory frequency is around 5 to 8 hertz. And at that frequency, the predominant property of the lung we're looking at is resistance. So we choose that frequency for a particular reason. So what are we measuring with forced oscillation technique? What we're measuring is based on the concept that the lung doesn't function at all evenly. The lung functions, even in healthy, non-diseased individuals, asymmetrically and unevenly. We call this heterogeneous function or heterogeneous ventilation. Some parts of the lung function with really wide airway caliber, low resistance, and a lot of ventilation, and other parts of the lung function less well or poorly with low ventilation and smaller airway caliber. And that's demonstrated by these two compartments, which I've designated as fast and slow. We can take the relationship between pressure and flow, and using some simple mathematics, we can calculate two mechanical properties. One is resistance. Resistance reflects the airway caliber, the mean airway caliber of the system, and this funny term called X, the X factor or reactance. And reactance is very much sensitive or related to the difficulty in getting the oscillations down into those regions where caliber is narrow or ventilation is poor. So that's why I've written recruitment. That X number, reactance number, is very sensitive, theoretically, to uneven ventilation and uneven airway caliber. So theoretically, it's a very good measure of lung function. It's function at normal tidal breathing. So you have to remember that, and it's not looking at function during a forced maneuver. So these are both resistance, reactance, and spirometry are telling us very similar abnormalities in the lung, but they're not the same. The good thing is that it's passive, and in our studies, patients don't mind doing this test at all. They definitely do this anytime over spirometry at home. So I think that just summarizes what I've just said. The RRS stands for respiratory system resistance. XRS stands for respiratory system reactance. So we've looked at using forced oscillation in the home, and it is a highly feasible thing for patients to do at home. Even the elderly patients with COPD that we've studied, and studies like that are ongoing, they actually do the test really well at home, and looking at the quality control, it's excellent in most of them. The other advantage of this is that the devices that we're using, and probably many devices that are to come, allow immediate data transfer. So they come to a central place, and the complex analyses can be done straight away. And the really exciting thing from my point of view is that there's miniaturization will allow these devices to be really small. And I can imagine in the future that we will have a device that will be of this size, about the size of a glasses case, and it will plug into a smartphone. You will make your measurements, and they will get sent to a central repository that, if your doctor was interested in looking at those, they could have access to those, and the analyses could be done on them. These are the current devices that are commonly used in Australia. One's an Italian device, one up at the top, the Resmon device. They've made a device specifically for home monitoring, and the device below, which is the Tremorflow device, which is really made towards laboratory use. The one above has a computer inside it, so it's a bit bigger. The one below has a separate, you have to plug it into a computer. And once these signals are sent to a center, or whoever the center responsible is, I think analyses something like this are going to be used. This is a recent paper describing a kind of a time series or variability analysis of resistance measurements. In the top graph, you see the resistance on the y-axis over time in days, and you can see the variability over time in an asthmatic individual. The funny looking graph below is a graph of risk or a conditional probability. The graph matches the risk of high spikes in resistance, i.e. airway narrowing, in relation to the nature of the variability during a given time. So you can see that the idea behind this is that if you look at for every individual, after a few weeks of monitoring, you will have an individual behavior or variability score. And for any given day of monitoring or days of monitoring, you can give a probability of somebody heading out of control. So this is kind of like a sophisticated way to look at peak flow variability. It's the same idea. And the ROC curve you see on the right shows you that potentially this could be very useful. Now, the caveat with that is that this is looking at changes in resistance, not actually symptoms. So that study, it still has to be done, but it shows the principle that these sort of analyses, which now can be done in anybody, probably within somebody's smartphone, have potential for real clinical use. This slide is from a paper that is in press, and this is a single case, pediatric case, of a child who has difficult to control asthma. And on the y-axis, you see both resistance going upwards and reactance going downwards. The dotted lines show what would be close to normal. You can see that the red dots over time start going upwards and vary. The blue dots in the middle section start going downwards. So they've now started varying outside the limits of what that person, we would deem that person to be normal for that person. So those happen to relate to a pending exacerbation. And then with treatment, and that exacerbation was due to the child stopping taking his inhaled corticosteroid. And then with restarting the treatment, you can see the change in resistance. So this really is another demonstration of proof of principle that this might work. And you can see the time scale in many days. So just to finish off and allow perhaps some time for some questions if you have some, is that home monitoring, that it provides objective measurements, and as I've tried to stress through this whole talk, objective measurements I think are the way to go and the way of the future and the way we're going to change the way that we think, study and treat asthma. Lung function variability despite adequate treatment is a hallmark of severe asthma. And symptom perception, be wary of it because it varies greatly between individuals and we can get ourselves into a lot of trouble if we don't appreciate that variability. The FOT is I think one of many different ways of monitoring people that I think will change and improve the way that we do things. And although our current devices are purely experimental and they're large and they're expensive, we've got the technology now to make it really small and very, very usable. And I think hopefully costs will come down. So just in a general sense, I guess just to reinforce my message about the future of asthma management is in objective measurements, whether it be lung function testing or other body secretions. We're heading towards individualized or precision medicine, and to do it, we need these. And this is how we're going to manage asthma better. So that's how I'd like to finish this. Thanks for joining the webinar, and happy to answer questions if you have any.
Thank you very much, Greg. So now I'll open the discussion to, just a second, sorry. Open the discussion here, or open the talk for questions. We had one question, or several questions here online, which maybe I'll just start with. And I guess one of the main ones relating to Greg, the case you presented there, is with a patient with no symptoms despite big defects in lung function. Is that a matter of a poor receiver, or a poor symptom perceiver rather, or what's happening there?
Yeah, absolutely. Like we all lump them into this category called poor perceiver, and I think this is how we define what poor perception is. But frustratingly, nobody knows what the cause of this is, because we don't understand the generation of asthma symptoms in the first place. And being a poor perceiver is also equally matched by being an over perceiver. So over perceivers get overtreated, poor perceivers get undertreated. And I think the relevance, clinical relevance, is that poor perceivers are at risk of basically death, because once they start perceiving symptoms, it's almost too late. So whether it's neural, whether it's mechanical, whether it's inflammatory, absolutely no one knows. But this is such a great example of one of the types of asthma that we deal with. And there are many types of asthma. This is just one of many. And another really important research question that needs to be answered: what is the generation of asthma symptoms? How does it vary? And what's the difference in poor perceivers?
Any questions from the audience here?
In that case, I may have missed it, but Greg, did you present any airway inflammation data? So, poor lung function, future reversibility, no symptoms. Was there any pheno?
That does sound a bit like Vanessa.
Yeah.
No, I use pheno, but later on down the track, if he fails to gain control after I've stepped up treatment. So he's quite allergic, and I guess you could argue that the pheno would be really useful, because if it was elevated, I'd really strongly suspect he's not taking his medication. But that's the way I use the pheno. I won't use it till a bit later on down the track. If he comes under really good control, then I would obviously bring back his doses after a while. And when I say a while, it would be about 6 months' time. I wouldn't consider reducing his high-dose medication if I managed to bring him under control for quite a long period of time, because of that really bad lung function. The pheno, and therefore I might use pheno later on when I'm starting to think about down titration. Of course, it will have occurred to many of you that we would not be able to use biologics in this man. His symptom perception is just too low, even if his eosinophil count, which is actually, I should have put it on, but I can't remember. I don't think it's that high actually. So I think he's going to present a lot of treatment challenges, I can imagine, unless he comes under really good control with the addition of a long-acting bronchodilator.
Yes. Thanks, Greg. That kind of segues into one of the questions online, which I posted to both of you. So what about, so you've shown here that there's this entire presentation has been on lung function and the importance and relevance, and you've shown that there's a big disconnect potentially between that and symptoms. What can you say then about all the studies that are using symptoms quite often as a primary outcome of treatment response, and how well that then those kind of study results can apply to the asthma population?
Do you want to start, Bridget?
I don't really know where to start. I think that symptoms and lung function have to go hand in hand. I would never make a diagnosis of asthma based on lung function alone. Not that I would actually make a diagnosis myself, because I'm not a doctor. But in terms of studies that are using, for example, the ACQ as an outcome measure, which is about symptom control, as outcome measures, I think that they're still very useful, because they look at a lot of different aspects of the symptoms that a patient or a subject has at the time. But I think that lung function is always useful in terms of objective measures to actually see what we're doing and what we're seeing. As I demonstrated with a couple of the cases that I showed, that sometimes people can have symptoms, but we don't see them when we actually perform. We don't see deficits when we actually perform lung function either. So we shouldn't disregard symptoms if we see normal lung function.
Yeah, I agree. I think we're missing half of it. When in those studies, we're only looking at half the picture. We're only looking at the way that treatments control symptoms, and in some people, some of their symptoms in those studies, they're probably not even due to asthma at all. So that reduces the probably overall efficacy of the treatment. But then in other patients, they might be effectively controlling symptoms, and we see this often, effectively controlling symptoms, and yet the lung function remains poor or partially improves. Or we have persisting bronchodilator response, and the long-term consequence obviously is fixed airflow obstruction. And this is a problem with many of our patients that we see for a long period of time. They become COPD-like, and I think the whole COPD overlap question comes into this, because it's almost a lack of concern about protecting lung function in asthmatics. So I think what the person's question is a pointed one and extremely relevant. We're just neglecting a whole lot.
And I mean, very few of the clinical trials of current and upcoming drugs have shown an effective change in lung function measurements. So it almost points to, are we missing out on an entire arm of potential treatments?
Yeah, absolutely. Yeah, I just couldn't agree more. And I would bet if the FDA decided one day that they're going to say, right, change normalization of FEV1 or showing altering the decline in FEV1 or some other outcome, it would force a whole lot of us to change the way that we think about our aims of what we're doing with asthma, not just treating the ACQ or the ACT.
A question from Lisa Wood was just asking Greg, relating to the FOT assessment, are there reliable reference values that are available for adults and children?
Thanks for the question, Lisa. For children, there are reference values out there, but I think they're suboptimal. The ATS CRS document, which is currently being updated and which is dragging on forever, that'll have a table of all the best and relevant predicted values. But for adults, I think that they're suboptimal, and there at least needs to be for Australian values. The difficulty is that there are probably slight differences for each device, and I don't think that the FOT community are ever going to get over that one, is that it may be device specific.
Thank you very much. I think we've run out of time for the session now. There's a few more questions, but I think we'll have to wrap it up, unfortunately. So please join me in thanking the speakers, Bridget and Greg King.
Thanks, Dave.
And thank you very much to the audience for logging in. All the best. Thank you both.
Thank you.